There's some of these topics that you never encounter or very rarely encounter in the emergency department, but then when you encounter them, you kind of need to know things because it's quite urgent. And then today I want to focus. I'm not going to go into details at all. I just want to present you some really quick pearls. And hopefully that's what you're going to remember next time you see a myasthenia gravis patient in the ED. So mini pearls for the ED this morning. I don't have any conflict of interest to declare. And in terms of the objectives for today, I want to, at the end of this presentation, we should all be able to name 3 of the medications to avoid in myasthenia gravis patients. I want you guys and us all to be able to explain how do we assess for respiratory failure in myasthenia gravis patients, and then try to list some specific considerations when you decide that a patient in respiratory failure from myasthenia gravis needs to be intubated. And hopefully you're going to be able to bring that to the bedside whenever you have one of those sick patients. So what is myasthenia gravis? So myasthenia gravis is actually an autoimmune disorder, very rare, usually affects either the young woman, so between 20 to 40 years old, or the elder men between 50 and 70 years old. It will be diagnosed in the emergency department. Most of the time, the patients we're going to see are going to be the ones that are already diagnosed, that are on cholinesterase inhibitor as a chronic therapy, and they're going to come in for some reason, like any other patients in the emergency department. Well, what you have to remember for the pathophysiology that is quite complex is that it's basically an autoimmune disorder where you have autoantibodies, antibodies that are attacking yourself. And what they're doing, they're destroying the receptors at the postsynaptic membrane on your skeletal muscles. So here's a muscle, and the antibodies, they will not only destroy your receptors, so you'll have less receptors overall, but they will also bind at the remaining receptors. All that to say that basically what's happening is you're having muscle fatigability because you're not able to activate your muscles anymore. Your acetylcholine cannot do the work because all the receptors are either bound to antibodies, or almost all, or destroyed by them. So this is the whole pathophysiology behind it. The way we treat it, or we try to treat it, is we give a cholinesterase inhibitor. So they're going to basically stop the degradation of acetylcholine in that, in between both your, so at the cleft here, so in the space here, you're going to have these cholinesterase inhibitors that are going to inhibit acetylcholine breakdown. So you're going to be able to overcome a little bit that blockage. We're going to illustrate some of my pearls by giving you a case. So now that you know that these guys are on cholinesterase inhibitor and they're at risk of having muscle fatiguability, let's kind of discuss this. So you have a 62-year-old man who's known for myasthenia gravis, on neostigmine regularly, very compliant, followed at the Jewish, and having very good care. When I present to emerge, because he's been having this cough and fever for 2 days. Okay, let's say this is before COVID. Okay, this is just before COVID. You get him an x-ray and then you realize he has a right middle lobe pneumonia and maybe something kind of weird on the left lower lobe, but you're concerned that this gentleman has a community acquired pneumonia. So you get your pen and your prescription and you're about to prescribing some good antibiotics, just like Dr. Grad told us a few weeks ago. But I don't know, you're kind of tired and you decide you're going to give him levofloxacin. The pharmacist calls you and tells you, might not be the best choice for this patient. So my pearl number 1 is that you really want to think twice before you prescribe any, and I really insist on the any medication to myasthenia gravis patients. They are, I'm sorry, the slide is a little bit blurry, but I think it's a great table. It's the best I found. The common medications that are precipitant actually for myasthenia crisis, or that can really get your patient sick or bad in terms of the rest function, are these medications. And then very surprisingly, most of the antibiotics we use for pneumonia will be on that list. So all the macrolides, the fluoroquinolones, so the levofloxacin, the azithromycin are contraindicated for myasthenia gravis patients. You really want to avoid them. Here they mentioned the low-risk antibiotics. So clindamycin is one of those you want to try to avoid, but the penicillins usually are okay. Also important to mention, I think the cardiovascular drugs, a patient comes in fast AFib, beware that if you prescribe some of them, you might actually be precipitating a myasthenia crisis. And then some of the miscellaneous that are actually very interesting to know, the corticosteroids, although they're very important in the management of exacerbation of myasthenia gravis crisis, they can actually precipitate you in a crisis. So if you decide to prescribe prednisone for gout or prednisone for some urticaria that has been kind of lasting for too long, be very careful. Magnesium, remember that magnesium can weaken your muscle. So this is something to be careful. Magnesium replacement in those patients could be a concern. And then IV contrast. Again, the studies are not phenomenal, but there's been some reports where people were getting intravenous contrast for CT scans, for example, that precipitated them into a crisis. So good list to know. And then you're going to say, well, Laurie, this is a lot of medication. How do I remember this? So myasthenia.org has a list, and also they have a list that is reviewed every year. So they just released the 2021, where you can see the evidence behind it and the ones you should really not prescribe. So ciprofloxacin is like a no, absolute no. I'm going to share the PDF of that list of drugs after the presentation, so you can have it in your iPhone, always ready whenever you have one of those patients. So that was pearl number one. So this guy, you give him, I'm not sure, amoxicillin high dose, and you send him home, and he comes back 2 days after because he's getting worse. He's just feeling weak, maybe a bit of nausea. He's having trouble eating despite the antibiotics. So you go on and you go and assess him, and he's pale. He looks weak, a bit diaphoretic, still febrile. My problem number two is beware of myasthenia crisis. So what is myasthenia crisis? Because I keep talking about that term for a few minutes now. Myasthenia crisis is basically a patient who's going into so a myasthenia gravis patient who's going into respiratory failure. So remember that these patients are have easy fatigue, so they're going to really get muscle fatigue easily. The concern is if they have muscle fatigue of the bulbar muscle, so the muscle that handles the secretion, but also the diaphragm and the respiratory muscle. Once they get there, they're too weak. They might not be able to handle their airway or support their own breathing, and you might have to intervene. So that's it. So this gentleman, basically, I'm very concerned that he's having a myasthenia gravis. So when you see a patient with an acute medical condition, and that includes pregnancy, that includes patients who are post-op or going to go for post-op. So the number one will be an infection, but any acute medical precipitant can actually give you a myasthenia crisis. So honestly, all patients coming in to emerge, you should always have an approach to know how to assess for their airway, or to see if maybe they could be going into respiratory failure or myasthenia crisis. So one of the rapid bedside techniques, so you have this guy, has this pneumonia, doesn't look so good, you're concerned that he could be going into a myasthenia crisis. A rapid bedside is, as you're doing the interview, ask him to do that test. So you count as long as you can with a single breath. Most of us, we can do 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, until 30, even more, without having to take another breath. Myasthenia gravis patient, when they're very fatigued, you're going to see they're really not going to be able to count as much, and something less than 20 is a concern. And again, that's just a rapid screening test. That's not like the holy grail of respiratory assessment for myasthenia gravis patients. I think what's very important is to kind of know that part of the evaluation for respiratory status is the pulmonary function test. This, you ask your RT to do the PFTs. There are really two things you want to know. I want to know the forced vital capacity, so FVC of my patient. As per Scott Weingart, as per many sources, this is actually the best evaluation of the respiratory function of the patient, because you can assess the inspiratory force, the expiratory force. You can also assess the pulmonary compliance, and it is something that you can actually trend over time, that FVC. Anything that is less than 15, okay, is abnormal, and you should be concerned that this patient might be in respiratory failure or going there. The other important marker that I find useful is the negative inspiratory force. So you ask the patient to basically inspire against, and then there's little myometer where you can actually see. And if you have, normally it's going to be more than 70, but for myasthenia gravis patient, less than 20 is a concern. I use both in conjunction. I think it's a good thing to have in mind, the numbers, because you want to know what's abnormal whenever the RT comes back to you with those results. So pulmonary function test. The evaluation of myasthenia gravis failure or myasthenia crisis is actually a lot of things together. It's not just a NIF that is less than 20. It's not just a count number that is abnormal. It's really, you want to assess the airway of the patient. So are they able to lift their head off the bed? Are they able to swallow their own saliva? How's their work of breathing? If they're in horrible rest distress, well, you're kind of done here. Don't start asking them for NIF and forced vital capacity. You want to look at vital signs. My personal thing, these guys should be an end-tidal CO2 and look for the trend if ever I'm concerned that they're heading towards the intubation. The overall appearance, I just talked about, if they look horrible, don't follow your clinical judgment. And again, PFTs have to be in your evaluation. And I would say that all of that needs to be assessed every hour or two for these patients. And you want to look at the trajectory or the trend over time. Because some of these patients, they will get better or they will just stay stable and they might not need to be intubated. If they are intubated, trust me, it's going to be hard to get them out of the ventilator. But some of them will be heading towards rest failure and you have no choice and you have to commit. So this guy, now he's been a day in your emerge because obviously there are no beds. ICU is full with COVID patients. He's unable to get out of bed. It looks like he's choking on his secretions. And the trend that you've been doing with your PFTs, it's not looking great and it's really going down. And now you're very borderline with them numbers. So problem number 3 is don't hesitate to intubate those patients. And if you have to intubate them, it's exactly the same as you would do normally. So I remember then intubating one of them and I was very concerned that, oh my God, there's one of them that I'm not supposed to use, but the guy is crashing. I'm like, I don't know. So we're going to use, I guess, this one. This is what I want you to remember. You need to adjust your paralytic dose for intubation, but there's no absolute contraindication to any of your paralytic. Succinylcholine can be used for a myasthenia gravis patient. The thing is, you're going to have to use a higher dose. Instead of using the 1 or 1.5 milligram per kilogram, you're going to have to go to 2. Why? Because remember that myasthenia gravis patients are resistant to Sux. So Sux is like acetylcholine. You have less receptor for your Sux to bind to, but you also have cholinesterase inhibitor that can prolong the effects of Sux. It's not going to be degraded. It's going to stay forever. It's also a little bit unpredictable depending on where you are in the stage of the disease and what you're taking with medication. But Sux can be used. Just remember, you need to use it at a higher dose. Rocuronium remains the drug of choice. So if you think about it, great. But one of the considerations with rocuronium is you want to use it at a lower dose. So half the dose that you would use, let's say, for COVID patients, which will go to 1.2, because they're very sensitive. You have less receptor, so they're going to go bind right away and give you the paralysis. So usually the agent of choice for intubating myasthenia gravis patients. So your guy was very sick, community-acquired pneumonia on antibiotic. You decide to intubate him. But what if you decide not to intubate? You just follow the trend. He's good. I think he's going to be into the floor and get some close monitoring. How do you manage a myasthenia crisis? Well, this is my pearl number 1 and final pearl. When in doubt, just call a friend. So don't start managing myasthenia crisis on your own, giving steroids or IVIG or plasmapheresis. Call the neurologist. It's going to be site dependent. It's going to be patient dependent. It's also going to be situational dependent, depending if the patient is intubated, or if you think the patient can go outpatient, or if you think the patient is going to be admitted. So your best friend is a smart person called the neurologist for the management of myasthenia gravis patient. And at any time, if you're not sure about what medication to give them a quick call and tell them the situation. They will be able to help you. So mini presentation. Take home for this one is that really think twice before you prescribe anything to myasthenia gravis patient. Know your resource, where to find, what type of medications are safe, especially for those common infections we have in the ED. Beware of myasthenia gravis and know how to recognize respiratory failure in patients. And don't forget, this is a trend. This is an absolute number. And also, if ever you go and intubate a patient, don't worry about the paralytic choice. Worry a little bit more about just adjusting your doses. So I hope it was useful. I know it was quite fast.